I welcome you all on the behalf of Department of ENT Head Neek Surgery to this CCR. We are privileged to have Dr. Suresh Chandraji Sharma as the director of our department. Dr. Achal Gulati sir recently got Lifetime Achievement Award 2025 at the National Conference held recently. We have a faculty support of 2 professors, 2 associate professors, 2 APs and 3 SRs. Our AP, Dr. Priyanshu Gupta, she has contributed a lot to this CCR. Besides this, we have 4 PG students per year. That comes out to be 12 PG students at a time. In the last year, we had OPD of more than 21,000 patients and major OT was more than 2,000. We have a state-of-the-art temporal bone dissection lab where our PG students are routinely doing cadaveric temporal bone dissection. In the audiometry lab, we routinely do audiometry, tympanometry, bara and speech therapy. In the minor OT, all the scopies and minor routine procedures are being done. Recently, we had the vertigo clinic under the vision of our chairperson, Dr. Vikas Chandra Sonkar. We are doing various tests related to vertigo there. In 2023, we hosted national level conference. In 2024, EarCon was hosted in our department. Besides this, we are organizing various CMEs on regular basis. More than 103 manuscripts are credited to our faculty and students. Out of this, there are more than 80 papers in various national and international journals from our faculty and students. So with this, I invite Dr. Shivi Mathur, our third-year resident, to present the case.
Thank you, ma'am. A very good morning, respected dignitaries, senior faculty members, teachers and colleagues. Today, we shall be discussing a case of a 35-year-old male with acute onset dizziness. Our patient, a 35-year-old male, resident of Dausa, farmer by occupation, belonging to the lower socioeconomic class, who presented with the chief complaints of dizziness, unsteadiness while walking, reduced hearing in the right ear, and ringing sensation in the right ear since 1 month. He was apparently asymptomatic 1 month ago when he developed a single sudden episode of dizziness while sitting. The episode lasted for 48 hours. It was associated with nausea and vomiting. Vomiting was non-projectile in nature and it contained food particles. The episode was followed by unsteadiness while walking. He had partial symptomatic relief on medications and no aggravating factors were noted. He also complained of reduced hearing in the right ear since 1 month, which was also sudden in onset, non-progressive, non-fluctuant and persistent in nature. He also developed ringing sensation in the right ear since 1 month, also sudden in onset, non-progressive, non-fluctuant and persistent. On further inquiry, there was no history of loss of consciousness, presence of obvious trigger mechanisms, blurring of vision or double vision, no history of unusual movements of objects, taste disorders, facial numbness or facial paralysis. There was no history of head and neck trauma, neurological deficits like dysarthria, diplopia, numbness, weakness of the limbs or dysphagia. There was no complaints of palpitation or breathlessness or complaints of involuntary movements of the limbs, uprolling of the eyeballs or incontinence of the bowel and the bladder. The past history. He had a history of upper respiratory tract infection 2 months back. There was no history of trauma or prior surgeries and no known comorbidities like diabetes, tuberculosis, asthma, hypertension or thyroid disorders. Personal history. He was vegetarian with a normal appetite, normal bowel and bladder habits and a normal sleeping pattern. He was non-alcoholic, non-smoker and had no history of excessive caffeine intake. The family history was unremarkable. No similar episodes were reported in the family members. Medical history accounted for no prolonged drug intake or drug abuse. Treatment history. After the acute episode was over, after 2 days, he felt a little better. He consulted a general practitioner at a primary health center, documents for which were not available. He was unsatisfied with the consultation and his symptoms persisted. Therefore, he was referred to a general physician at a private hospital. Documentation of the consultation with the physician revealed that he had nystagmus, which was horizontal in the resting state and it increased on horizontal gaze. The findings were more prominent on the left side as compared to the right side. NCCT brain, MRI brain, and a CT angiogram of the brain and the neck were also done and were reported to be normal. He was discharged on tablet Vertin 24 milligrams BD, tablet Strugeron Fort 75 milligrams OD, and was called for follow-up after 15 days. He had minimal relief in his symptoms and therefore he discontinued his medications without a medical advice. Complaints of imbalance, tinnitus, that is the ringing sensation in the ear, and reduced hearing in the right ear persisted. Therefore, he consulted the ENT OPD at Mahatma Gandhi Hospital. To summarize, we have a 35-year-old male with history of a single acute episode of dizziness with sudden onset of reduced hearing and ringing sensation in the right ear since 1 month, presently complaining of unsteadiness while walking, reduced hearing and ringing sensation in the right ear. Now, since our patient complained of dizziness, let us understand what dizziness actually means. Dizziness, to our surprise, is an umbrella term comprising of lightheadedness, vertigo, oscillopsia, and disequilibrium. Lightheadedness includes transient slowed consciousness, faintness, or loss of consciousness, also termed as syncope. Vertigo, it is a sensation of self-motion when no self-motion is actually occurring. Oscillopsia, it is defined as the movement in the form of oscillation of the visual surroundings. And disequilibrium, that is difficulty in maintaining balance while sitting, standing, or even walking. Now, in patient parlance, all the 4 terms are synonymous with dizziness, or in the patient's language as we know it as chakkar. But actually they are not synonymous and have varied clinical approaches. Therefore, the onus of reaching at a clinical diagnosis and for differentiating amongst the 4 types, a thorough clinical examination is must. Now, since our patient did not have any complaints of loss of consciousness, lightheadedness can be ruled out. He did not have any history of movement in the form of oscillations, therefore oscillopsia can be ruled out. Let us examine our patient for further evaluation. On general physical examination, he was well nourished, conscious, cooperative, and well oriented to time, place, and person. The vitals of the patient were normal. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. The systemic examination was unremarkable. On local examination, it included the evaluation of the nose, throat, and the neck, along with the ear examination. The nose and throat examination was unremarkable. No significant findings were noted in the examination of the neck as well. On ear examination, bilateral preauricular region, pinna, and the postauricular region were normal. On the otoscopic examination, the bilateral tympanic membranes were intact and the rest of the examination was also normal. Bilateral facial nerve examination was normal. There was normal tympanic membrane movement on cerebral speculum examination and on valsalva. Horizontal jerk nystagmus was present at the resting state with its fast component towards the left side. It was maximally noted by looking onto the left side and it reduced with gaze fixity. On tuning fork examination, release test for the frequency of 256, 512 and 1024 Hz was positive bilaterally. The Weber's test was lateralized to the left ear, that is the normal ear, and absolute bone conduction test was reduced on the right ear and was equal to the examiner's ear on the left side. This is the pure tone audiometric examination of the patient, where the image on the left side shows the examination of the right ear, and the image on the right side shows the findings in the left ear. The graph is suggestive of sensory neural hearing loss, severe in category. Vestibular function tests were done. The Rombert's test was positive, that is, it showed swing on the right side. The tandem gait test was also positive, where the patient had swing to the right side. The video alongside represents the tandem gait test. The Unterberger's test was also positive. Further, there was no pass pointing, no rebound phenomena. Titubation was absent, intention tremors were absent, and dysdiadochokinesia was absent. The finger nose test, the knee shin test were normal, and the patient had a normal speech. On positional maneuvers, on performing the Dix Hall pipe test, no torsional nystagmus was seen. On roll test, no geotropic or epigeotropic nystagmus was seen. And in the supine head hanging position, no vertical downbeating nystagmus was seen. The video alongside represents the Dix Hall pipe test. Prior consents from the patient were taken for the examination video. So based on the examination findings of a patient, he was found to have imbalance while walking with swing on the right side and severe sensory neural hearing loss with tinnitus. Now, based on the clinical history and examination findings of a patient, it can be noted that a patient had vertigo. That can be due to a central cause or a peripheral cause. A neurology consult was taken for further evaluation and management of our patient. I would like to invite Dr. Kanika Suri from the Department of Neurology to take the case further.
A very good morning to all. I am Dr. Kanika Suri from the Department of Neurology. So we got a referral from the Department of ENT to further evaluate and rule out potential causes involving the central nervous system. Upon taking detailed history, the patient reported an acute onset continuous vertigo persisting for 1 month, accompanied by imbalance while walking and tinnitus and hearing loss in the right ear. A detailed neurological examination was performed. Higher mental functions were normal. In the cranial nerve examination, only the right eighth cranial nerve was affected, showing sensory neural hearing loss, and rest of the motor and sensory examination was normal. Thereafter, a cerebellar examination was performed, revealing impaired tandem gait with the patient swing to the right side. All other appendicular cerebellar tests were normal. Subsequently, a vestibular examination was done, including a HINS plus examination. So HINS plus is an acronym which stands for HI is head impulse test, N stands for nystagmus, TS is test for skew, plus we test for hearing loss. So head impulse test in our patient was abnormal, showing corrective saccades to the midline with head rotation. Nystagmus was observed on left gaze, characterized as horizontal and jerky, with suppression on gaze fixation. The test for skew showed no deviation. Additionally, the patient had hearing loss in the right ear. Summarizing the case, a 35-year-old male presented with acute onset continuous vertigo with gait ataxia, tinnitus and hearing loss in the right ear. On examination, there was left gaze suppressible nystagmus with abnormal head impulse test and sensory neural hearing loss in right ear. So a diagnosis of acute vestibular syndrome was kept. Acute vestibular syndrome is a clinical syndrome characterized by sudden onset, severe, continuous vertigo lasting for more than 24 hours, often accompanied by nausea, vomiting, and imbalance while walking. It typically is caused by a disorder affecting the vestibular system, with peripheral cause being more common than the central cause. This algorithm was adapted from Continuum 2024, outlining the approach. So after we suspect the acute vestibular syndrome, we need to check for the skew deviation, head impulse test, nystagmus with relation to fixation suppression. As in our case marked in yellow, there was no skew deviation, an abnormal head impulse test, unidirectional nystagmus with fixation suppression. If any would have been contrary or all negative, central cause would have been highly likely. However, in our case, it was all positive, so we move on to the next step, which is to evaluate new onset sensory neural hearing loss, severe postural instability, or hyperacute onset of symptoms. If these features are absent, the cause is highly peripheral. However, in our case, they were all present, so it states that the condition could be either central or peripheral. Elaborating the central causes of acute vestibular syndrome, namely vascular, infectious, demyelinating, vestibular migraine, or drugs or toxins. There was no history of any drug intake or no exposure to any recreational toxins, so drugs and toxin as an etiology was ruled out. There was no history of headache or migrainous symptoms. Moreover, there were no any other brainstem aura other than vertigo, like visual aura, which can be normally seen in vestibular migraine. So it was also ruled out as an etiology. There was no relapsing remitting course rather than a continuous persisting vertigo. No other associated symptoms like diplopia, optic neuritis, or other long track signs. So demyelinating as a pathology was ruled out. So we were left with vascular and infectious. Due to persistence of symptoms for more than a month, TIA was ruled out. Cerebellar strokes were ruled out with testing as there were no appendicular cerebellar signs. Moreover, the nystagmus in cerebellar is bidirectional and it is often not suppressible. Acute cerebellitis was ruled out as there was no persisting fever, no appendicular cerebellar signs. Lastly, a possibility of anterior inferior cerebral artery occlusion was kept. So anterior inferior cerebral artery supplies a part of cerebellum, middle cerebellar peduncle and pons. Its occlusion can cause cerebellar and brainstem infarction, leading to multiple cranial nerve involvement with symptoms such as dysarthria, facial paralysis, vertigo, vomiting, hemiataxia, which was not present in our case. However, a small branch of ICA, the labyrinthine artery, supplies the cochlea, vestibule, semicircular canal, and vestibulocochlear nerve. Its occlusion as an N artery with no collateral circulation causes sensorineural hearing loss, tinnitus, severe acute onset vertigo, imbalance, and difficulty in walking due to ischemia of the cochlea and vestibular apparatus, which can be seen in our case. It has also been reported that vertigo may precede infarction by weeks or months, indicating transient ischemia of the inner ear or vestibular nerve. So a possibility of labyrinthine artery occlusion was kept. To rule this out, we ordered for a neuroimaging including MRI of brain and MRI angio of brain and neck vessels. To brief us upon that, I would like to invite Dr. Harish Meena from the Department of Radiodiagnosis.
Rather than ordering, requested.
Requested.
Good morning, everyone. I'll be discussing the radiological finding of this case. So, MR brain and MR angio was done. MR brain was within normal limits, and in MR angio, we found that the ICA was well visualized and labyrinthine artery was certainly visualized, originating from the ICA's branch, ICA's loop. This is on the left side. Sorry, this is on the right side. This is on the left side. And we can see labyrinthine artery. It's not very well visualized, but certainly visualized. And this is the ICA's loop, and this is the basilar artery from which the ICA is originating. So MR angio was basically normal, and the labyrinthine artery was seen originating from the ICA's loop. There was no significant occlusion of any major arterial branch, no evidence of any arteriovenous malformation, no evidence of any aneurysm was seen. So from our side, there was no occlusion of ICA. The neuroimaging findings were discussed with the Department of Neurology and suggesting that a central cause was less likely. A possibility in this patient, central cause was less likely in this patient. So I would like to call upon Dr. Kanika to further discuss the case.
So after ruling out potential causes involving the central nervous system, the patient was referred back to the Department of ENT with a strong suspicion of peripheral vertigo. Before we proceed to explore the peripheral causes of vertigo, I would like to involve Dr. Rozy Paul from the Department of Physiology to provide us with valuable insights into the normal physiology of vertigo.
Good morning, respected teachers and seniors. As it has been discussed that this 35-year-old male who presented with the giddiness and detailed workup was done by the ENT and the Neurology department, and the diagnosis of acute vestibular syndrome was made. Now we'll understand the basic physiology of vestibular system. So as you can see that these are the components of the vestibular system. It is basically containing of three semicircular canals. These are the anterior, posterior and the horizontal one. And the otolith organs, which we can see in the dark color, they are the utricle and the sacule. The arrangement of the semicircular canal is like that. They are arranged mutually perpendicular to each other. They continue in a sac-like structure, which we can see, that is the ampulla, and the utricle and sacule. Basically, the hair sensory receptor, they are present in these ampulla and the utricle and sacule. These are the sensory receptor, these are the hair cell. Now we will understand how there is generation of the action potential in these hair cells. Basically we can see this hair cell, they have these cilia-like projection, which basically contains the actin filament. Whenever there is movement of head, there is movement of the semicircular canal and there is movement of the fluid inside the semicircular canal, which causes the displacement of these cilia towards the lateral end. These tips, they have got the potassium channel over them. Whenever there is bending of these cilia towards one direction, towards the tallest one, there is opening of these potassium channels. So there is movement of the potassium from outside towards the inside of these hair cell. And we can see at the base of the hair cell, we have got the calcium channel also. So whenever there is movement of potassium channel, these calcium channel, they also open, and there is influx of the calcium channel, which fuses with the synaptic vesicle, which we can see at the base of the hair cell, and there is release of the neurotransmitter, that is glutamate in this case, and there is generation of the action potential. Whenever there is no movement of the hair cell, as we can see in the third picture, there is no movement. There is no movement of this hair cell, and there is hyperpolarization. That means there is no generation of the action potential. So this is how the action potential is basically generated in these sensory cells. These are the two hair cells. One is the macula and other is the crystal. One is the macula and other is the crista ampullaris. As we can see, this macula, it is containing the modified hair cell, which are type 1 and type 2 hair cell. Again, we can see the cilia-like projection present over the hair cell, and they are embedded in this gelatinous membranous structure, which is containing the calcium carbonate crystals. And the other image is showing the crista ampullaris, which is again the modified hair cell, which is present in the semicircular canal ampulla. It is containing an inverted cup-like shape, that is called the cupula. So whenever there is movement in the fluid, there is displacement of the cupula towards one side, and there is generation of the action potential. Whenever there is movement of head or eyes, they basically rotate to the opposite direction so as to maintain the gaze. So how it is occurring, we will understand this. There is the vestibulo-ocular reflex that is taking place so as to maintain the image in the right, so that there is no blurring of image. So as we can see, whenever there is movement in these semicircular canals, basically there is projection, the nerve fiber which arrange, they go up to the vestibular nerve nucleus, and further they project towards the abducens nerve nucleus, and further they project to the oculomotor nerve nucleus, which innervates the rectus muscle of the eye, so that there is movement in the opposite direction of the eye. So this is how the gaze is maintained. So to further continue with the discussion of the case, I would like to invite Dr. Garima from the ENT department.
Good morning, Emeritus Chairperson, sir, senior faculty members and my colleagues. After understanding the ocular reflex, we now proceed to the VNG examination of the patient. So the video nystagmography examination of the patient was done. In this, first we take the subjective visual vertical. This is a test which is done in order to see if the visual acuity lies within the normal range of the patient and he doesn't have any movement disorders per se. So here, since we see for this patient it was in center, so therefore the posture and the axis of the patient was normal. Next, we did the dynamic visual acuity test. This is done in order to check the visual acuity of the patient. We asked the patient to trace the object which is flashed on the video And when the patient reacts to the flashing image, then we can see if the visual acuity of the patient is intact or not. In our patient, it was absolutely normal. Then we did the head shaking test. In this, we take the head of the patient and we give a jerk to the patient, and we see for the nystagmus which has been generated with the head jerk. In this, the head shaking test was positive and the nystagmus slowly and gradually decreased with time. Here we see the head shaking test was done and we could see the nystagmus for a moment, and after which it was reduced. Then we did the spontaneous nystagmus test. Spontaneous nystagmus test is done when we ask the patient to focus on one image in front, and then we notice for the nystagmus which is present in the eye. In our patient, the nystagmus was positive. Therefore, we have a doubt that it could be a peripheral pathology which could lead to the spontaneous nystagmus. Here again, we see the spontaneous nystagmus of the patient was positive. Then we did the gaze-induced nystagmus. In the gaze-induced nystagmus, we flash an image to the patient. Then the image is laterally moved to the comfortable visual acuity side of the patient. So once the image moves, we ask the patient to trace the image with his eye. After tracing the image, we can see the nystagmus is generated or not in the patient. So as in the previous spontaneous nystagmus, we saw the nystagmus had a fast component in the left side. When we see both these eyes, the eyes which are there in the red block shows the right eye, the one in the blue block shows the left eye. So on spontaneous nystagmus, the inference was that the nystagmus had a fast component on the left side. So generally we see when there is a pathology at one side of the vestibular apparatus, the fast component would be on the opposite side. So therefore we have a doubt in this that maybe the pathology was in the right side or the right vestibular system was not working well. Therefore we had a fast component on the left side. In the gaze-induced nystagmus, we saw that on the left side there was no nystagmus induced, but after a latent period of say about 5 seconds, we could see nystagmus in the right side. This showed that the pathology or there could be inactivity of the right vestibular system. After the gaze-induced nystagmus, we did a skew deviation test. In this, we alternately check both the eyes for abnormal movements, but it reflects a cerebral pathology. Since our patient, we have ruled out the possibilities of cerebral pathology. It was confirmed here as well. The skew deviation test was found to be negative. The smooth pursuit test, generally there are two components, a smooth pursuit and a saccade. Smooth pursuit per se means that when the object is moved very slowly, we have to trace the object, say about 10 to 15 degrees if it is moving per second. So smooth pursuit was negative in our patient. The patient had no nystagmus when the object was moving from one to the other side very slowly, about 10 to 15 degree per second. It was negative, therefore we rule out a central pathology, as smooth pursuit is present in cases of cerebral pathologies. The random saccade, in random saccade what we are doing is, we are flashing alternatively the images in different directions, and we ask the patient to quickly look at the directions where the images are being flashed. So this works for basically a very instant movement is seen in the eyes, so which could lead to a jerky nystagmus if there is a cerebral pathology. But in our case there was no pathology, therefore we could not see any nystagmus. Then we did a Valsalva induced nystagmus. In Valsalva induced nystagmus, we generally increase the patient, the pressure of the patient and through the Valsalva maneuver. When there is a pathology in the lateral semicircular canal, say it's a dehiscence or a fistula, there when we induce a Valsalva induced nystagmus, Valsalva maneuver is done, then the nystagmus is induced since the pressure is raised. But in our case it was not so, so we rule out a semicircular canal dehiscence. Then we did a hyperventilation test. In this we asked the patient to rapidly breathe. With the rapid breathing, there is a CO2 washout in the patient which could lead to the induction of the nystagmus. But in our case it was negative, therefore we also rule out the cerebral pathology. Positional Dixolpite test. This is almost similar to the one which we perform in the regular OPD when the patient comes. But in video nystagmography, we have a Fresnel glass which is put in the patient, and this is a 20 diopter glass which can even pick very small nystagmus which can be missed by naked eyes. So here what we do is, we place two electrodes on both sides of the Fresnel glasses, and those electrodes can help us pick the degree of nystagmus as well. In our patient, the Dixolpite maneuver was negative and we could not see any positional change, positional nystagmus induced. Therefore, we can rule out the positional roll of nystagmus. Then we did a supine roll. The supine roll is done in order to check for any pathology if it is present in the posterior compartment. It was negative in our case, so therefore we rule it out. Then we did a positional head hanging test. It is done in order to see if there is any pathology in the anterior test, which was negative in our case as well. Caloric test was done. Caloric test works on the principle that when the stimulation are given in the external auditory canal, the vestibular apparatus stimulates. So what we do is we take two temperature waters, that is 7 degrees up and down from the normal temperature, that is 30-degree cold water and 44-degree warm water, and the ear canal is irrigated alternatively with both the cold and the warm water. When the irrigation is done, we can see nystagmus in the eyes of the patient. So the irrigation is done for a period of 40 seconds. Here what the inference that we got was when the left canal was irrigated, we could easily see the nystagmus in both the cases, in the warm and the cold water. But when we irrigated the right canal, the latency period for generating the nystagmus was little more, which indicates that this could be a case of right vestibular canal hypofunction. This is done with the cold water. So the left side, we could see it was normal, but the right side, the latency period was increased, which indicates that it was a hypoactive right side. This is a butterfly chart. Basically, this is a representation of the caloric test. In this, there are 4 quadrants, to depict the left side of the eye and to depict the right side of the eye, with warm in one quadrant and the cold in one quadrant. And seeing the butterfly chart also, we can easily take the inference that it is a right side hypofunction which is happening. So now, coming to the differential diagnosis, since we've already ruled out the central causes, if we take peripheral vertigo into consideration, the possible differentials which could be made could be BPPV, Meniere's disease, vestibular neuronitis, perilymphatic fistula, vestibular concussion, acoustic neuroma, and labyrinthitis. Benign positional vertigo. So, to see for benign positional paroxysmal vertigo, we saw that since we know that it has to be paroxysmal, our case was an acute case, and also there was no nystagmus which was induced on changing the position of the patient, therefore BPPV could be ruled out. Then we see for Meniere's disease, our patient's attack was acute. Then there was, in case of Meniere's disease, there are severe attacks with remission. In our case, there was only an episode of single attack, therefore even the Meniere's disease could be ruled out. Coming to vestibular neuronitis, here the attack is spontaneous and acute, and even tinnitus is present as in our case, but in case of vestibular neuronitis, there is no history of hearing loss, but our patient had a hearing loss, so we could rule out vestibular neuronitis as well. Then coming to perilymphatic fistula, we saw that on performing the Valsalva induced maneuver, there was no nystagmus seen, so it can be ruled out with that as well. Then vestibular concussion was also ruled out, since we saw that the vestibular concussion has a higher history and ours was just a brief history of 1 month. Acoustic neuroma was also ruled out with the radiological investigations. So we are left with one diagnosis, which is the labyrinthitis, which is supported in a patient. The patient had tinnitus, the patient had hearing loss, the patient had a severe acute episode of vertigo. So the final diagnosis comes out to be right labyrinthitis with right vestibular hypofunction due to inadequate compensation. Coming to the management of the patient, so our aim to manage the patient is we are dealing with all the 3 symptoms with which the patient presented to us, being it hearing loss, tinnitus, and the vestibular rehabilitation also has to be done. Picking one by one, first we did the hearing rehabilitation of the patient. So generally when any patient comes to us in the ENT OPD with a complaint of a sudden sensory neural hearing loss, the first approach to us of ours to the patient is we prefer injecting a steroid injection, which can generally get back the hearing of the patient. So we did the same for this patient. We took intratympanic steroid injection procedure for this patient. So what we did was we took a 24.5 gauge needle and we injected 0.5 ml of dexamethasone in the posterior inferior quadrant of the patient. Here we see we've taken the needle, we've punctured the tympanic membrane, and then after puncturing the tympanic membrane, we inject 0.5 ml of dexamethasone in the posterior inferior quadrant of the patient. One thing that we have to keep in mind is that we have to instruct the patient that for the next 2 to 3 minutes, the patient should not perform Valsalva maneuver or should not yawn in order to opening of the eustachian tube so that the dexamethasone will be displaced. The aim is it should be kept in the biliary cavity for around 2 to 3 minutes. After that, the patient can absolutely be mobile and perform any procedure he wants. So we gave the steroid injection. After giving the steroid, there were 2 steroid injections which were given to the patient. And this picture shows the audiometry. The above audiometry is the previous audiometry of the patient, and the below audiometry is one which was done after 1 week of the steroid injection. We noticed that there was no significant improvement. There was only little improvement. This is actually because generally the study says that when the patient presents to us within a window period of 2 weeks, the maximum benefit in sensory neural hearing loss, sudden sensory neural hearing loss with the dexamethasone injection is seen in the period of 2 weeks. Since our patient presented to us after 1 month, therefore we could not see a significant improvement in our case. So the next aim for hearing loss was completed by giving a hearing aid trial to the patient. In this, our patient, we gave a in-the-canal hearing aid which was most comfortable to the patient. Then we come to the tinnitus rehabilitation. So we know that there are a lot of pharmacological drugs which have been given on and off for tinnitus. That is, carovarine is given. Then we have vinprocetine. Then we have paracetam, ginkgo biloba, antidepressants, and also caffeine. But there is no proven role of any of these medications. So we switched to a tinnitus retraining therapy. So what is tinnitus retraining therapy? It is a therapy in which there are various components which are included. We basically train the patient in order to avoid the noise which is producing tinnitus to the patient. So the component is we give a white noise to the patient. A white noise, when it is given, the patient's full attention goes to the white noise. It acts like neuroplasticity. So he's not able to focus on the tinnitus voice which was irritating him before. So when a continuous white noise is given, his attention goes to that. So therefore he deviates from the tinnitus noise, and therefore it reduces tinnitus sometimes. Then second, we also do a cognitive behavioral therapy to the patient, which means that we have to constantly counsel the patient that it is okay to have tinnitus. It is just a functional pathology. It will not do any harm to you in any other way. Like people are always concerned about having some big disease which can lead to this, the symptom which can lead to a big disease. So we tell the patient it is a functional pathology, it can be improved, it can be even cured sometimes. So after the cognitive behavioral therapy, we focus on the habituation. Habituation also, again, the patient becomes habitual to the white noise, therefore the perception of tinnitus decreases. Then masking. Masking is one thing which is done along with the hearing aid only. In our patient also it was done with the hearing aid. So a masker is put in the hearing aid and a proper frequency is set in order to distract the patient from the tinnitus noise, and because of the masker, the patient is free from tinnitus. Then we also gave some pharmacological drugs as an adjunct therapy, which was capsule Tinex, which is a carovarine, NEL3, which is ginkgo biloba, paracetam, vinprocetine, and multivitamin. Coming to the vestibular rehabilitation. So the crux of vestibular rehabilitation is basically vestibular compensation. It occurs because of the sensory conflict. So more is the sensory conflict, more will be the vertigo, and better is the compensation. This means that both our sides of the vestibular apparatus, they move hand in hand. If one becomes less, the other makes it a point to compensate for that. So when there is a sensory conflict, that when we know that one side of our vestibular apparatus is going low, then the other becomes active and it works more in order to compensate the other one. So therefore we say that vestibular sedatives should never be given for more than 2 days in cases of tinnitus and vertigo. Why? Because if you give vestibular sedatives for a longer duration, what happens is the sensory conflict reduces and therefore the vestibular compensation cannot occur. So it is always preferred to give vestibular sedatives for a very brief duration, say about 48 hours only. But there is no drug with adequate and convincing evidence to claim that it enhances the compensation. And the compensatory mechanism in the brain is almost active for the first few days after vestibular assault. So basically it is always ideal to when a patient presents to you with the complaint of vertigo or tinnitus, it is always ideal to act very fast and to diagnose it very fast, so that if you have a good and a quick diagnosis, you can easily make the patient symptom free after some time of the therapy or rehabilitation. Now I would like to invite Dr. Maghna from the Department of PMR, who helped us with the vestibular rehabilitation of the patient.
Good morning, respected dignitaries. I, Dr. Maghna Khatri, Junior Resident at the Department of Physical Medicine and Rehabilitation, will be discussing the rehabilitation management in our patients. So after the patient was referred to us, he was examined, and on examination we found that he had neck stiffness, painful restriction of movements, and tender myofascial triggers present in bilateral trapezius, scalene, and sternocleidomastoid muscles. On posture assessment, he had forward head posture, where his neck was shifted 1 inch forward. He had balance issues on walking, and he was swaying towards right side on the Romberg test. Dizziness handicap inventory, being a commonly used subjective scale in vestibular rehabilitation, developed in the effort to quantify the handicapping effects of dizziness and vertigo on a patient's well-being. It consists of 25 items separated in 3 categories: functional, physical, and emotional. Every yes response is given 4 points, sometimes is given 2 points, and no is given 0 points. Scored above 60 are associated with severe dizziness and recurrent fall. It can be used to determine improvement after rehabilitation, and a decrease in DHI of 18 is considered clinically significant process. On our patient, the score was 54. After which a rehabilitation plan was curated according to the needs of our patient. He was put on beta-histine 60 mg BD along with vestibular rehabilitation therapy and range of motion, stretching and strengthening exercises of neck and paraspinal muscles of neck, balance and gait training, as well as posture correction. Now, goals of vestibular rehabilitation therapy was to improve his activities of daily living, to improve his vertigo, enhance gaze stabilization, and enhance postural stability. Now, for components of vestibular rehabilitation therapy, we have 3 main components: habituation. As we know that our patient had vestibular hyperfunction, where there is unequal vestibular input in one ear. Now, symptoms are tried to decrease through repeated exposure to provocative stimuli. In vestibulo-ocular adaptation, as vestibular rehabilitation focuses on improving the vestibulo-ocular reflex to stabilize vision during the head movements, our purpose here is to enhance gaze stability and reduce dizziness. In sensory substitution, there is a use of an alternate intact sense for an impaired sense. It helps by enhancing the use of visual and somatosensory cues for balance and postural control, and may assist in functional recovery. Now, vestibulo-ocular adaptation, it works on an important 3-neuron vestibular reflex affected by the stimulation of semicircular canals that create conjugate eye movements of equal and opposite direction to the movement of head. It allows for stabilization of the image on the retina and leading to the clear vision when the head is moved. It has 2 components, eye velocity and head velocity. Now, gain of vestibulo-ocular reflex is equal to the ratio of eye velocity to head velocity. An ideal gain in a normal person is 1:1. But in vestibular hyperfunction, which our patient had, VOR gain decreases by as much as 66%. So he was put on gaze stabilization activity, where he was asked to move head side to side, keeping his eyes fixed on a stationary object. And progressing with difficulty, he was asked to move the head and the target in opposite direction. He was asked to do this exercise 2 to 3 times daily. And a proper rehabilitation protocol was started under the supervision of a PMR specialist after taking informed consent from our patient. Here are some exercises, range of motion and stretching strengthening exercises that he was put on, and along with balance and coordination exercises and gait training. Now, I would like to call upon Dr. Garima again to discuss the case further.
Thank you. This is the follow-up video of the patient after 3 months. The patient came to us previously with a DHI score of 54, and after 3 months we could see that the DHI score reduced to 18. Now, what is labyrinthitis? Labyrinthitis is inflammation in the membranous labyrinth in the inner ear and typically presents with vertigo, nausea, vomiting, tinnitus, and hearing loss. So, seeing the definition, our case had all these features, and we could hence come to conclusion of labyrinthitis. The take-home message: every peripheral vertigo is not BPPV, benign positional paroxysmal vertigo. It needs to be evaluated. The CE-MRI and CECT brain rules out only the possibility of the central vertigo. However, VNG differentiates between central and the peripheral vertigo. The early diagnosis of labyrinthitis can prevent irreversible SNHN, as we discussed, that if the patient would have presented to us within a window period of 2 weeks, we could easily improve the hearing of the patient with an injection of steroids. And prolonged use of vestibular sedatives hampers the vestibular compensation. And early mobilization of vertigo patients help in improving sensory conflict and in turn improve the compensation. And just prescribing cinerazine is not the definitive treatment and is only increase the problem. Why? Because it will inhibit the vestibular compensation of the patient, which could have been easily developed otherwise. And also a multidisciplinary approach is required, which we were fortunate enough to have in our institution. This is the DHI score which was improved. So in the end, I would like to extend my gratitude towards the management of our university for providing us this platform to enhance our knowledge, and also the CCR review committee who've been behind us for improving each day. The Department of Neurology, Department of Radiodiagnosis, Department of Physiology and Department of PMR for their input to our presentation, the supporting staff and also the patient and his relatives. Thank you so much.